I want to talk to you today about a group of medications that almost nobody thinks of as medications at all. Ibuprofen, naproxen, diclofenac, the anti-inflammatory painkillers known collectively as NSAIDs. You can buy them in a supermarket alongside the bread and the milk. They cost very little, they work well, and most people take them without a second thought for a bad back, for arthritic knees, for a headache, for aching hips. And here's the reason I want to spend proper time on them today. Of all the medications discussed on this channel, these are the ones most likely to be taken regularly by an older person without any doctor knowing about it at all. And they are also, in this age group, among the most consistently cautioned against drugs in medicine. They appear on every international list of medications to avoid or use with great care in older adults. And the reason is not that they are bad drugs, they are genuinely effective. It is that they carry three specific risks to your stomach, to your kidneys, and to your heart. And every one of those three risks rises sharply with age and is multiplied by exactly the other medications that people over 70 are most likely to be taking. So today, I'll explain how these drugs work and why the same mechanism that relieves your pain causes their harms, the three risks in proper detail, the combinations that genuinely matter, the situations where these drugs must be avoided entirely, the safer alternatives that work well for the problems people usually take them for, and how to use them sensibly if you and your doctor decide they're right for you. And I want to be balanced because this is not a video telling you that you can never take an ibuprofen. It is a video telling you what you are actually taking. Let me begin with the mechanism. Let me explain how these drugs work because it explains everything that follows with unusual clarity. Throughout your body, there are chemicals called prostaglandins, and they are made by two enzymes called COX-1 and COX-2. Prostaglandins do several very different jobs depending on where they are. At a site of injury or inflammation, they produce pain, swelling, and fever, and they are made largely by COX-2. But elsewhere, made largely by COX-1, they do essential protective work. In your stomach, they maintain the mucus layer and the bicarbonate that protect the lining from your own acid, and they maintain the blood flow that keeps that lining healthy. In your kidneys, they keep the small vessels supplying the filtering units open, which is particularly important when blood flow is reduced. And in your platelets, they are involved in clotting. Anti-inflammatory painkillers work by blocking both enzymes, and that single fact is the whole story of this video. They block the prostaglandins that cause your pain, which is the effect you want, and simultaneously they block the prostaglandins protecting your stomach lining and maintaining your kidney blood flow, which are the effects you don't. So the harms are not incidental side effects, they are the same mechanism working in the places you didn't intend, which is why they cannot be entirely engineered away. So these drugs block the chemicals that cause pain and by the same action the chemicals that protect your stomach and your kidneys. Let me take the three risks in order, starting with the stomach. Anti-inflammatory painkillers cause ulcers and gastrointestinal bleeding, and this is the most common serious harm. They do it in two ways at once, by removing the prostaglandin protection of the stomach lining and by making platelets less able to plug any bleeding that starts, and the risk is present with tablets regardless of whether you take them with food because the main mechanism is systemic rather than local contact. Now, the crucial point for this audience, age is one of the strongest risk factors, with the risk of a serious gastrointestinal event rising substantially over 65 and further over 75, and the other risk factors are a previous ulcer or bleed, which is the single strongest predictor, infection with the stomach bacterium Helicobacter pylori, higher doses and longer duration, and above all, the combinations I'll come to. And here is what makes this so dangerous in older adults. These bleeds are frequently silent until they are severe, because older people often experience less pain from ulcers, so the first sign may be collapse from blood loss, or it may be a gradual, invisible anemia presenting as tiredness and breathlessness, which is exactly why unexplained anemia in an older person on these drugs needs investigating rather than simply treating with iron. So, learn the warning signs: black tarry stools, vomiting blood or material like coffee grounds, and severe or persistent upper abdominal pain, all of which are urgent, alongside the quieter signs of unexplained fatigue, breathlessness, and pallor. So the stomach risk is ulcers and bleeding. It rises steeply with age. It is often painless until it's severe, and previous ulcer disease is the strongest predictor. Second, the kidneys. And this is the risk I'd most like people to understand because it's the least known. Your kidneys depend on prostaglandins to keep the small vessels supplying the filtering units dilated. And this matters most precisely when kidney blood flow is under strain, which happens with dehydration, with heart failure, with existing kidney impairment, and with age itself, since kidney function declines gradually in everyone. Take away those prostaglandins with an anti-inflammatory, and the vessels constrict, blood flow falls, and kidney function drops, sometimes abruptly. And here is the combination that doctors specifically warn about, and it has a name: the triple whammy, which means an anti-inflammatory painkiller taken together with a diuretic, a water tablet, and an ACE inhibitor or ARB, such as ramipril, lisinopril, losartan, or candesartan. Each of those three affects kidney blood flow through a different mechanism, and together they substantially increase the risk of acute kidney injury. And now consider how common that situation is: an older person with high blood pressure on a water tablet and a ramipril, who buys ibuprofen at the supermarket for their arthritic knees and never mentions it because it doesn't feel like a medication. That combination sends people to hospital. Add in an episode of dehydration from a stomach bug or hot weather, and it becomes considerably more dangerous. So if you take blood pressure medication of any kind, please treat over-the-counter anti-inflammatories as something to ask a pharmacist about rather than something to buy freely. And these drugs cause fluid retention and raise blood pressure in their own right, typically by a few points, which sounds small but genuinely undermines blood pressure treatment and can tip someone with borderline heart failure into decompensation. So the kidney risk is reduced blood flow to the filtering units. It multiplies dangerously in combination with water tablets and ACE inhibitors or ARBs, and these drugs also raise blood pressure and cause fluid retention. Third, the heart, and this one has become clearer over the last 2 decades. Anti-inflammatory painkillers, with the exception of low-dose ibuprofen taken occasionally, are associated with an increased risk of heart attack and stroke, and this applies across the class, with diclofenac carrying a comparatively higher cardiovascular risk and naproxen generally regarded as carrying the lowest. The risk is dose-dependent and duration-dependent, and it is most relevant to people who already have cardiovascular disease or significant risk factors, which describes a great many people over 70. They also worsen heart failure, both through fluid retention and through their effects on the kidneys, and heart failure is one of the situations where these drugs should generally be avoided altogether. And there is a specific interaction worth knowing for anyone taking low-dose aspirin for heart protection. Ibuprofen can interfere with aspirin's antiplatelet effect if taken shortly before it, essentially competing for the same site on the platelet, which can reduce the cardiac protection aspirin was prescribed to provide. So if you take both, the timing matters, and it's worth asking your pharmacist about it. So the cardiovascular risk is real across the class, is dose and duration dependent, matters most in those with existing heart disease, and includes a specific interaction that can undermine your aspirin. Let me now give you the combinations that genuinely matter, because in this age group, harm usually comes from combinations rather than from the drug alone. First, anti-inflammatories plus anticoagulants, meaning warfarin, apixaban, rivaroxaban, or edoxaban, which substantially increases the risk of serious bleeding, and which, as I said in my blood thinner video, is a combination to avoid unless specifically managed by a doctor. Second, plus aspirin for the same reason. Third, plus corticosteroids like prednisolone, which markedly raises ulcer risk. Fourth, plus SSR antidepressants such as sertraline, citalopram, or fluoxetine, and this is a genuinely under-recognized one because those drugs also affect platelet function, so the combination meaningfully increases gastrointestinal bleeding risk. Fifth, the triple whammy with diuretics and ACE inhibitors or ARBs. Sixth, plus lithium and plus methotrexate, whose levels both rise. And seventh, plus other anti-inflammatories, including ones people don't recognize as such, so taking ibuprofen tablets while also using a supermarket cold remedy containing ibuprofen, which is common. And I want to add a word about topical preparations because they are genuinely a good option. Anti-inflammatory gels and creams applied to the skin over a painful joint deliver the drug locally with much lower blood levels, and they have reasonable evidence for effectiveness in knee and hand osteoarthritis while carrying substantially less risk to the stomach, kidneys, and heart, which makes them a particularly sensible choice after 70. So the dangerous partners are anticoagulants, aspirin, steroids, SSRI antidepressants, and the diuretic plus ACE inhibitor combination, and topical gels are a genuinely safer route for joint pain. Let me be clear about who should avoid these drugs entirely or nearly so. If you have had a previous stomach ulcer or gastrointestinal bleed, these should generally be avoided because the recurrence risk is high. If you have significant chronic kidney disease, they should be avoided. If you have heart failure, they should be avoided. If you have had a heart attack or stroke or have significant cardiovascular disease, they should be used only with medical advice and generally avoided. If you take an anticoagulant, avoid unless your doctor has specifically decided otherwise. If you have poorly controlled high blood pressure, avoid. If you have severe liver disease, avoid. If you have asthma, be cautious, because a proportion of people with asthma experience worsening symptoms with these drugs. And if you are over 75 and taking several other medications, the sensible default is caution and a conversation rather than free use. That is a long list, and it covers a substantial proportion of the people watching this, which is precisely why these drugs sit on the caution list for older adults. So previous ulcers, kidney disease, heart failure, cardiovascular disease, anticoagulants, and uncontrolled blood pressure are the main reasons to avoid them. Now let me give you the alternatives, because I don't want to leave anyone in pain, and there are genuinely good options. First, paracetamol, which is generally the first choice oral painkiller in older adults because it has none of the stomach, kidney, or cardiovascular risks of anti-inflammatories. Its honest limitation is that it is less effective for inflammatory pain, but for a great many people, it provides adequate relief, and the key point is that it must be taken properly, meaning regularly at an adequate dose rather than occasionally when the pain is already severe, and the maximum dose should be reduced in people who are frail, of low body weight, or who have liver problems or drink significantly, and it should never be exceeded because paracetamol in overdose is genuinely dangerous. Second, topical anti-inflammatory gels, which I've already mentioned, and which are the sensible substitute for oral anti-inflammatories in joint pain. Third, and this deserves emphasis, the non-drug treatments, because for the conditions people most commonly take these tablets for, exercise is genuinely first-line treatment with better evidence than the tablets. As I described in my knee video, exercise is the recommended first-line treatment for knee and hip osteoarthritis ahead of medication, and strengthening the muscles around an arthritic joint reduces pain more durably than a tablet does. Add heat and cold, weight loss where relevant, walking aids used correctly, and physiotherapy. Fourth, for specific conditions, there are specific answers, so a corticosteroid injection into a single badly affected joint, capsaicin cream, or, for nerve pain, the specific medications I mentioned in another video, since ordinary painkillers work poorly for nerve pain anyway. Fifth, if an anti-inflammatory is genuinely needed, ask about adding a stomach-protecting tablet, a proton pump inhibitor, which substantially reduces the ulcer risk and is standard practice when these drugs must be used in higher-risk people. So paracetamol taken properly, topical gels, and above all, exercise and the non-drug measures, with a stomach protector if an oral anti-inflammatory is genuinely necessary. Let me tell you how to use them sensibly if you and your doctor decide they are appropriate, because there are situations where they genuinely are the right choice. A bad flare of gout, an acute inflammatory episode, a short course for a specific injury. The principles are these: use the lowest effective dose, use it for the shortest possible time, meaning days rather than weeks, and certainly not indefinitely without review. Choose the lower risk option, which generally means naproxen from a cardiovascular perspective or ibuprofen at low dose, and generally not diclofenac in older adults. Take it with food, which helps with nausea even though it doesn't prevent ulcers. Stay well hydrated and, importantly, stop taking it during any illness with vomiting, diarrhea, or fever, because that is precisely when the kidney risk becomes dangerous, which is the sick day principle I've described in several videos. Add a stomach protector if you have any risk factors. Tell every doctor and pharmacist that you take it, and this is the single most important practical point, because a drug bought at a supermarket does not appear on your medical record and cannot be checked against your other medications by anyone. And review it, meaning that if you find yourself taking it most days for months, that is a situation that needs a proper conversation rather than a repeat trip to the shop. So, lowest dose, shortest time, lower risk choice with food, stop during illness, stomach protection if at risk, and above all, tell your doctor and pharmacist that you take it. Let me be very clear about when to seek help. Seek emergency care for vomiting blood or material that looks like coffee grounds, for black tarry stools, for severe abdominal pain, for collapse or fainting, and for chest pain or stroke symptoms. Contact your doctor promptly for any new or persistent indigestion or upper abdominal pain while taking these drugs, and please do not simply treat it with over-the-counter remedies indefinitely, because that can mask an ulcer for unexplained fatigue, breathlessness, or pallor, which may indicate slow blood loss and anemia, for a marked reduction in the amount of urine you're passing, or new swelling of the ankles, which suggests the kidneys, for worsening breathlessness or swelling in someone with heart failure, and for wheezing or worsening asthma. And contact your doctor, non-urgently but genuinely, if you are taking these most days, if you take them alongside a water tablet, an ACE inhibitor or ARB, an anticoagulant, aspirin, a steroid, or an SSRI antidepressant, and if your blood pressure has become harder to control, because these drugs are a common and frequently unrecognized reason for that. And ask, at your next review, the simple question: given everything else I take and my kidney function, is it safe for me to use ibuprofen? And if not, what should I use instead? So bleeding signs and chest pain are emergencies, indigestion and unexplained tiredness are prompt, and regular use alongside the risky combinations needs a proper conversation. Let me paint you two pictures. First, picture a man of 74 with high blood pressure, taking a water tablet and ramipril, whose knees have been painful for years, and who takes ibuprofen most days, bought in packets of 16 from the supermarket, and has done for about 2 years. His doctor does not know because it has never occurred to him to mention it, since in his mind a medication is something with a prescription. Two things happen over that period. His blood pressure, which used to be well controlled, becomes harder to manage and his doses increase twice. And then he gets a stomach bug, spends a day and a half vomiting, keeps taking everything, including the ibuprofen, and is admitted with acute kidney injury. That is the triple whammy plus dehydration, and it is a genuinely common hospital admission. The frustrating part is how avoidable it was, because if his doctor had known about the ibuprofen, he'd have been switched to paracetamol and a topical gel years earlier, and if he'd had a sick day plan, he'd have stopped everything for 2 days and been fine. Second, picture a woman of 78 who took naproxen for a painful shoulder for about 6 weeks, and who became gradually more tired and breathless over that time, which she and her family put down to the shoulder, keeping her awake. She had no stomach pain at all. A blood test done for the fatigue found significant iron deficiency anemia, and the investigation found a bleeding ulcer, silent throughout. She had lost blood slowly for weeks with no warning sign except tiredness, which is exactly how these bleeds present in older adults. Two people, two different harms, and neither had done anything unreasonable. They had simply taken a medicine everyone thinks of as harmless. And let me speak briefly to those caring for an older parent or partner. The single most useful thing you can do about this topic is find out what they buy over the counter, because that is invisible to every doctor they see. And ibuprofen bought at a supermarket for arthritis is one of the commonest hidden medications in this age group. Check the cupboards and check for the hidden sources too, the cold and flu remedies, the combination painkillers, and the back pain gels, and get all of it onto their medication list. If they take a water tablet, an ACE inhibitor, an anticoagulant, aspirin, or an antidepressant, treat over the counter anti inflammatories as something requiring a pharmacist conversation rather than a shopping decision. Watch for the quiet signs of slow bleeding, the increasing tiredness, breathlessness, and pallor, because that is how ulcers present in older adults far more often than dramatic pain. Make sure a sick day plan exists, because the combination of an ordinary stomach bug and these drugs is a genuine route to hospital. And help them find alternatives that actually work, since telling someone in pain to stop their painkiller without offering anything instead is not a plan. And the real answer is usually paracetamol taken properly, a topical gel, and the exercise program that treats the underlying joint problem. So let me draw this all together calmly. Anti-inflammatory painkillers work by blocking the chemicals that cause pain and inflammation, and by exactly the same mechanism they block the chemicals that protect your stomach lining and maintain the blood flow through your kidneys, which is why their harms are inseparable from their benefits. Those harms are 3 ulcers and gastrointestinal bleeding that rise steeply with age and are frequently painless until severe reduced kidney blood flow that becomes genuinely dangerous in the triple whammy combination with a water tablet and an ACE inhibitor or ARB, enduring any dehydrating illness, and cardiovascular risk including heart attack, stroke, worsened heart failure, and raised blood pressure. The dangerous partners are anticoagulants, aspirin, steroids, SSRI antidepressants, and blood pressure medications. And the people who should generally avoid these drugs include anyone with a previous ulcer, kidney disease, heart failure, cardiovascular disease, or uncontrolled blood pressure, which is a large proportion of people over 70. And the alternatives are genuinely good: paracetamol taken regularly and properly rather than occasionally, topical anti-inflammatory gels which deliver the benefit locally with much less risk, and above all, the exercise and non-drug treatments that are first line for the arthritis most people are treating. So here's what I'll leave you with, straight and clear. First, tell your doctor and your pharmacist that you take these, because a medicine bought in a supermarket is invisible to everyone treating you and cannot be checked against anything else you take, and that single omission is behind a great deal of the harm. Second, if you take a water tablet, an ACE inhibitor or ARB, an anticoagulant, aspirin, a steroid, or an SSRI antidepressant, treat over-the-counter anti-inflammatories as a pharmacist question rather than a shopping decision. Third, if you take them most days for joint pain, ask about switching to paracetamol taken regularly plus a topical gel, and take the exercise treatment seriously, because it works better than the tablet in the long run and carries none of these risks. Fourth, stop them during any illness with vomiting, diarrhea, or fever, because that is when the kidney risk becomes real, and have a sick day plan for your other medications too. And fifth, know that in older adults these bleeds are often silent, so treat unexplained tiredness, breathlessness, or pallor as a reason for a blood test rather than an inevitability of age, and treat black stools or vomited blood as an emergency. These are effective medicines that are genuinely useful in the right person for a short course, and they are also the most commonly taken unrecognized medication in this age group, sitting in kitchen cupboards, invisible to every doctor, quietly raising blood pressure, straining kidneys, and thinning stomach linings. So take care of yourself, go and look in your cupboard, put what you find on your medication list, and take that list to your next appointment. And because the decision about whether these drugs are safe for you depends entirely on your kidneys, your heart, your stomach history, and everything else you take, please treat this as a conversation with your own physician. Treat new indigestion or unexplained tiredness as a prompt call, and treat black stools, vomited blood, or chest pain as your reason to seek emergency care immediately.